Welcome to the Iota Plus podcast. In this series, we speak every week with a specialist in gynae ultrasound. And this week, it's Dr. Nina Cooper from Imperial College in London, who is our guest. Thank you, Nina, for coming.
Thank
and
you for
could you
having
explain
me.
us what's your area of research?
Yeah, so first of all, thank you so much for having me on the podcast. I'm delighted to be here. So my area of interest is the kind of ultrasound profile of ovarian masses found in pregnancy.
Why in pregnancy?
Well, ovarian masses are actually quite common in pregnancy, and it's a unique setting where we have otherwise healthy women coming in for scans. And many times, in fact, up to 75% of women will have some sort of simple cyst on their ovary. So it's a unique scenario where we find pathology, but we don't really have any validated models for identifying which masses are benign and which ones are malignant.
True. In the previous Iota studies, we always patients that were pregnant were included, but we never analyzed the data, and it was only a very small minority. So I think it's very important that you do this research and that pregnant patients are examined as well. But how do you find ovarian tumors in pregnancy?
Well, they can either be found incidentally or they can be found because of symptoms. So women will have at least 2 ultrasound scans during a pregnancy, and a scan may be found on either transvaginal or transabdominal ultrasound, or potentially a woman presents with pain related to torsion of a mass, for example.
Okay. And do they look different in pregnancy, these ovarian tumors?
Well, I suppose it depends on what type of tumour they are. So just like in a non-pregnant women, we can see epithelial, sex cord stromal or germ cell tumours in pregnant women. The main time that things look different are in the context of endometriomas, and that's really where our kind of diagnostic conundrums really start. Because just like the endometrium decidualizes, endometriomas can decidulize, and that can present a huge diagnostic challenge for clinicians.
Yes, because suddenly you see these populations with high blood flow, and they look really suspicious for malignancy.
Exactly.
So it's quite difficult to distinguish them from borderline tumors, and then you're always in a difficult situation to balance the type of treatment. So what would you propose in these circumstances?
Well, it's very difficult because if you know about an endometrioma before the pregnancy and you see a decidualized endometrioma in the same woman, then you can be quite confident in telling the woman that this is a benign process and you can expectantly manage her. So with serial ultrasound scans. It's a bit more tricky when you didn't know about it prior to pregnancy. We try not to intervene in pregnancy as far as possible because you're not just thinking about the woman, you're also thinking about her unborn baby, and there are implications of operating on pregnant women, of course. However, if you did suspect an invasive malignancy, then that's a slightly different story.
Yes. So you would only intervene when there's suspicious of malignancy, and if there's symptoms that really urge you to do something in pregnancy.
Exactly. So one of the other things that's really important is that you can't ignore symptoms in pregnant women. And of course, a torsion is an emergency in a pregnant woman just as much as it is in a non-pregnant woman. I think there is sometimes some reluctance to intervene just in case you're wrong, but certainly you wouldn't want to leave a pregnant woman with a torted ovary.
No, definitely not. And if you need to intervene, what's the ideal timing in pregnancy?
Well, there are kind of different schools of thought about this. So in early pregnancy, there is a slightly increased risk of miscarriage if you perform a laparoscopy before 12 weeks. Performing laparoscopy in advanced pregnancy is possible, but you have to think about the position of the gravid uterus. And then your option, of course, is in the 3rd trimester to wait until delivery, and you can perform either a cystectomy at the time of cesarean section if you're very worried about a mass, or if it's safe, you can wait until the postnatal period.
And of course, there's a difference, like you say, between borderline tumors and invasive tumors. How often do they occur in pregnancy?
Well, they're very rare in pregnancy. When we've looked back at our local data at Imperial, we've actually found that it was safe to expectantly manage borderline masses, and we didn't have any cases where they became an invasive tumour during the pregnancy period. So it was safe for us to wait until the postnatal period to intervene with these women.
Yes. Like you say, there are different schools, so I think some gynecologists, or certainly gynae-oncologists, are not, they're not really happy to wait and see. If they think that's a borderline tumor, they will try to operate as soon as possible. But of course, you can do, like in non-pregnant patients, fertility sparing surgery, and there's no need to have a very large intervention.
Yeah, of course.
And how can you distinguish then between benign and malignant if there's no Iota models available?
Well, that's a really good question. So at the moment, I think our best bet is expert opinion. Many of the other models that exist rely on a CA125 level, and of course that's universally raised in pregnant women, so it doesn't really guide us much
It's
further.
a lot of concern.
And again, using MRI to characterize masses, you can't use contrast in pregnant women, and so the additional diagnostic value is questionable really, unless you see invasive disease elsewhere.
Yes. And what about the benign descriptors? Are they helpful in pregnancy?
So the problem is that decidualized endometriomas will not fall into the benign descriptors. I suppose an endometrioma which has not decidualized would still fit into that category. We need to really prospectively validate them to check that they still perform just as well in the pregnant population. I suspect they will.
Okay. And do you envisage to develop specific models for pregnancy?
I think the main diagnostic challenge is going to be how do we differentiate between the solid components and papillation seen within a decidualized endometrioma. Mm-hmm. Part of me wonders whether radiomics will have a role to play in differentiating between a papillation seen in a borderline tumour and within a decidualized endometrioma.
Can you explain radiomics?
Thanks for asking me that. So my understanding of radiomics is it can look at the features of an image that we can't see with our own eyes. So it can look at the texture of an image.
Yes, it looks really at the texture. So you need solid tissue, preferably, and then see whether the homogeneity of grayscale pixels is different. And so it's a complex algorithm. It's actually part of machine learning that can hopefully help us to distinguish between benign and malignant. But the jury is still out.
Exactly. But I think that the Iota study gives us a unique opportunity to collect loads of good images from a variety of masses and potentially see if there is a role for machine learning here.
And what numbers are we speaking about?
Well, the Iota study, we have a minimum recruitment target of 855 women, and we're on our way to getting there.
Okay.
Yes.
And how many centers are involved at this moment?
So at the moment we have 28 centers involved in the study across 3 continents. Not all of those centers are live and recruiting yet, but 12 of them are.
Yes. Ethics approval seems to be a bit challenging.
I mean, we could do a whole separate podcast on the logistics of study setup.
Yes.
So I think there are some real challenges that we as academics are facing, particularly with data protection, safe transfer of data, and that can really limit up the speed with which we can set up studies.
Yes.
There are a lot of hoops to jump through these days.
And this is a non-commercial academic study. Is it not difficult to find contributing centers? How can you make people enthusiastic to take part if there's no reward in terms of finances or any other?
Well, this is, I like to think that people will want to take part for the good of the women in our centres, and hopefully having an Iota model which allows us to confidently characterise these masses will improve the way that we counsel women on a day-to-day basis.
Well, it's great to see, and that's what we experienced in previous Iota phases, that people are really enthusiastic to help and to take part. And there's really a feeling of friendship, a feeling of doing something valuable, and this is really great.
Yeah, I think the fact that there isn't a commercial outlet to this study is the reason why people are so happy to collaborate together, because really the patients are the centre of these studies.
Okay. Nina, do you remember any case that struck you particularly of a cyst or a tumour during pregnancy?
So there are a couple of cases which spring to mind. I think one of the things that we find quite often in our service is large cysts and how they're going to impact mode of delivery. So we had a case quite recently of a patient with a 25 centimetre cyst, entirely benign in appearances, but it was filling the pouch of Douglas and extending up into the left upper quadrant. And the entire uterus was displaced over to one side. And so the presenting part was unable to engage in the pelvis. So this was really a difficult case because we were trying to decide when was the optimum time point during the pregnancy to drain the cyst. She was really uncomfortable because of the cyst. It can often be quite hard to work out whether the discomfort they're feeling is from being pregnant or whether it is the cyst itself. And so we did a first cyst drainage at around 20 weeks for symptomatic relief.
And was it a unilocular cyst?
Yep, so it was a unilocular cyst, which on scan appeared to have anechoic content, but actually when we performed the drainage, it was quite thick mucinous content. But it was avascular with regular cyst walls.
Okay. So first you have to make sure that it's really a benign cyst. Otherwise we will never do a cyst
Precisely.
Drainage. But if you're confident about this and there's symptoms and there were clearly symptoms, then I think draining the cyst is quite a good method.
So we're now at the point where she's approaching her estimated delivery date, and we are trying to optimize the timing for cyst drainage. But one of the things that came up in discussion is sort of intrapartum cyst drainage and whether actually you can get obstructed labor in the context of a large cyst, which many of our obstetricians haven't had to deal with acutely before.
Mm-hmm. So it was still stuck in the pouch of Douglas.
Exactly.
Because sometimes the cyst goes up together with the uterus and then it's out of the pelvis and then it doesn't obstruct anymore, but in this case you need to do something.
Yeah. And we have a similar case, but in a patient where we're not entirely convinced that the cyst is benign, and so now we're in a more tricky position about deciding on mode of delivery, because she's a multiparous woman, the second case, and is quite keen to have a vaginal birth, but currently the presenting part is nowhere near the pelvis and we can't offer her a safe drainage.
And if you have to do a cesarean section, would you consider removing the cyst during the C-section?
So this is another one of the things that is quite a nuanced discussion. Some people feel that the risk of bleeding around the time of cesarean section is slightly greater in view of the increased vascular supply to the uterus. Other people feel that, well, why subject a patient to 2 operations? If you're doing a cesarean section, why not do a cystectomy? I guess the point is you have to be confident in what type of cyst is there so that you're doing the right operation for her.
It's true. We try to treat fibroids during cesarean section because these are really much more difficult and much more vascularized to remove. But in cyst, I think there's a good chance of doing this in a convenient, in a appropriate way.
Yeah, certainly. And there are a few patients of ours who are choosing to have cesarean sections unrelated to the cysts, and we do cystectomies for them if they wish.
Yes. And is it difficult to convince patients not to do a surgery if they know that they have a tumor of the ovary?
Yeah.
Because the word tumor is alarming, and so many of them might want to get it out as soon as possible.
Exactly. And that is one of the challenges, because certainly in the UK, not every obstetrician is confident doing a cystectomy. And so when you tell a woman that, well, we'll support you to have a vaginal birth, but there's a chance you might need an emergency cesarean section, and actually the person who can safely do your cystectomy might not be the person doing that operation, that can push women to electing to have a cesarean section so that they can be sure that if they do need an operation, at least they can have their cyst sorted out at the same time.
True. And when you do a surgery during pregnancy, what's the risk of the baby? What's the risk of the pregnancy?
So overall, it is safe to operate in pregnancy, but it has to be done for the right reasons. So there is some evidence that doing surgery in the first trimester can slightly increase your chances of having a miscarriage. And again, there is some evidence that perhaps operating in an advanced pregnancy, there is a slightly increased risk of preterm labour. But I think leaving an inflammatory process inside the abdomen, for example, an appendicitis or a torted ovary, that would increase those risks anyway. So I think it has to be on a case-by-case basis. The second thing to think about is the surgical approach. So modifying entry for advanced gestations, it may be appropriate to do a Hassan entry, for example, in a woman where the uterus is above the umbilicus.
Mm-hmm. Yes. And certainly in the second trimester, between 12-16 weeks, laparoscopy is still feasible.
Exactly. And we do that as well.
Okay. If you have a decidualized endometrioma, how quick after delivery do you see it transforming back to a normal-looking endometrioma?
So at the moment, we follow our patients up at any point between sort of 6 and 12 weeks postpartum, and you can already see signs of it returning to normal. Often they're not completely returned to their baseline appearances, but generally we follow them up every 3 months, and you see a gradual return to how it appeared prior to pregnancy.
Yes. And do you see any difference between borderline tumors and the decidualized?
Well, the borderline ones don't get better after pregnancy.
But I mean in terms of the populations, because populations can be highly vascularized in decidualized endometriomas. But they look different.
The characterizations of the populations are different. So decidualized endometriomas tend to have these nice, smooth, rounded papillations, which you don't necessarily see with borderlines. And other things with sort of seromucinous borderlines, you get these microcystic areas within the papillations, which can give you a clue as well.
Yes, and borderlines have more this cauliflower-like surface of the populations.
They just don't look as nice.
No, but of course there's overlap, and like always in medicine and certainly in imaging, there's really continuum, and it's sometimes really impossible to make a distinction between the two.
Exactly.
But wait and see, I think, is the first advice if you're not sure about what to do.
Yeah, and phone a friend as well. The more challenging cases that we have, there'll be 3 or 4 of us scanning these women together, all offering our opinions on the masses.
It's reassuring to the caregiver, but also to the patient.
Exactly.
So I think it's a good idea to ask a second opinion and a third opinion.
And sometimes more.
Yes, certainly for very difficult cases. Mm-hmm. True. Is there any other case that struck you while you were in training? Because you had a lot of training already.
Some of the things that I find quite interesting are the smaller masses, which you try to observe through a transabdominal approach. That is something that I'm still trying to improve on, is optimizing my images for transabdominal scanning. Particularly in advanced pregnancy, the masses can appear in all sorts of bizarre positions around the abdomen. And
true. Early in pregnancy, it's in the pelvis, and you can usually reach it with transvaginal scan, but later on, it's impossible in most of the cases. We
recently had a mass which was only seen on transabdominal assessment, and it was a solid lesion with a colour score of 4. Even transabdominally, it had a colour score of 4. And we followed her up postnatally. She had a cesarean section, interestingly, and intraoperatively, the ovary was just smoothly enlarged. The decision was to not do anything at the time because it was out of hours. And then upon follow-up, we're suspicious that she may have a Sertoli-Leydig cell tumour. So it's quite an interesting case to see in pregnancy. And actually, her androgenic symptoms have become more prominent since she delivered.
And sometimes you have fibroids that may be challenging in pregnancy because they might change as well, and they might undergo necrosis.
Exactly. We sometimes also see small pedunculated fibroids in the adnexa, which can look very much like an ectopic pregnancy, and that always produces a bit of a diagnostic conundrum.
The blob sign. It's a mess.
The acoustic shadows can sometimes help to differentiate between the two.
Are they reliable acoustic shadows?
Not always.
Not always, but they're more common in benign tumors,
exactly.
But it's not absolutely
It's
reliable.
A benign feature, certainly.
But it's like always, you cannot count on one feature alone. So that's why, for example, in the simple rules, you have to look at all the features together. And so if there's only benign features and no malignant features, it's most likely to be benign.
Exactly.
And as soon as you have one malignant feature, you need to be careful.
Yeah.
Nina, can you tell me how you got into medicine?
So I went to medical school in London. I was brought up in London and I didn't really want to leave. So I applied to Imperial College London and fortunately got a place. So I spent 6 very happy years there. And that's kind of when my love for obstetrics and gynecology really started to bloom. I did an intercalated BSc in reproductive and developmental sciences, and that was my first taste of academic obs and gynae, really.
And then you did traineeships in different specialties, and you ended up in gynecology.
Yes, so I did a bit of a unique route after I left university. So I did something called the Academic Foundation Programme. So for our non-UK listeners, when you graduate from medical school in the UK, you have to do 2 years of general training. And I applied for a specialist route for one of my 6 blocks to be in academia. So I worked at University College London for 4 months doing some research there, and then loved it, but hadn't actually worked in clinical obstetrics and gynecology. So moved to Queen Charlotte's Hospital.
It is different.
It is very different. And I thought, before I commit to 7 years of training, I better test out the specialty itself. But fortunately, I had 6 very happy months at Queen Charlotte's and decided that I wanted to stay there.
Even with the on-calls?
The on-calls are the best bit. That's where all the fun really happens. And that's where you learn the most, actually. So that never put me off the specialty.
That's true, because when people speak always about work-life balance, but I find it strange because work is part of life as well.
I have to say, when I'm in an operating theatre, I don't feel like I'm at work, and sometimes I can't believe I'm being paid to do surgery. It's just such a rewarding and enjoyable thing to be involved in.
And then you went into research.
Yeah.
Was this intentional, or how did you come to a research career?
So I'd always been interested in working academically, and that had kind of been a theme of my career up until that point. I did 2 years of obs and gynae SHO training, so the first 2 years, and I was approached by one of my now supervisors, Maya Almamar, when I was on call, and she asked me what I wanted to do, and I said, I think gynecology over obstetrics, I'm not really sure. And she said, I think I have a project you should be involved in. I had done a few small projects with the early pregnancy unit at Queen Charlotte's Hospital already, so they knew me a bit, but that was really where things began to change. And then since then, I've been working with yourself in the Iota group, running 2 studies.
Mm-hmm. But sometimes I have the feeling that gynae ultrasound in terms of research is a bit lagging behind obstetrics. But that's a benefit as well, because there's much more to explore. There's many new things to discover and to do research upon.
That's exactly true. And, I think particularly in the UK, you don't get trained very well in ultrasound unless you take some time out of the normal training program to develop those skills. And it's incredible how quickly your skills develop, how much you learn in a short space of time. And then by doing that, you suddenly find all of these extra things that you want to learn more about, and they haven't necessarily been researched yet. So there are these huge areas that you can expand into and really have some autonomy of thought, which I don't think you get to do in normal clinical practice.
True. And it's really important because it's really influencing your practice. I think that it's very difficult to practice gynecology without ultrasound these days.
And I was saying to somebody the other day that I have become so reliant on ultrasound as part of my routine assessment for any patient that I see. And I find it so strange when I'm not the person performing the scan for them, because for me it is now, I take my history, I examine the patient, and naturally ultrasound for me is the next step.
Yes. So you don't do screening, but if there's a problem, if the patient has pain or abnormal bleeding, you should do an ultrasound scan. And if you can do it yourself, it's so much rewarding, because you can immediately tailor the treatment and the management of the patient.
And it translates into your obstetric practice as well. So things like cervical length scanning for women presenting with threatened preterm labour. Having developed my transvaginal ultrasound skills, I now have something that is actually directly benefiting my pregnant patients as well. So it's just a skill set that's really invaluable in both obs and gynae.
Yes. Do you think ultrasound should be available always at night if you're on call?
I think it should be available to people that know how to use it. So ultrasound in untrained hands can be a false friend. It can falsely reassure you. And so we have been looking at point of care ultrasound and handheld ultrasound, as it were, to see whether that is something that would be really useful for somebody on call to have access to. So for those who don't know, you can get ultrasound machines that connect to your mobile phone, and you can get real-time images of a patient you're seeing in an emergency setting. The problem with that is that you can falsely reassure yourself that everything's okay when it's not, and it shouldn't be a substitute for a formal scan by somebody who knows exactly what they're doing.
True. Education, training is very important, and you should know your limits, and I think it's really building up, and you learn, and you continue to learn while doing it, and the more you do, the more you can be confident. But even then, ultrasound cannot replace histology. Ultrasound cannot replace everything. So but it's a very efficient tool to triage patients, to tailor the management. in an effective and an optimal way.
Exactly. And I think it just improves the patient's experience overall, because they can come and see you for a problem and you can give them a fairly good idea about what you think may be going on and plan onward care. So it saves them having an extra trip to the radiology department and then a follow-up appointment. So in terms of sort of health economics, it's beneficial as well.
You talked about ultrasound in pregnancy. Is there also another area where ultrasound is lacking at this moment, or knowledge of ultrasound on ovarian tumors is lacking?
So one of the things I'm really interested in is pediatric and adolescent gynecology and the characterization of adnexal masses in women under the age, well, girls under the age of 18. The quality of data available for characterizing adnexal masses in this population is really, really lacking, and there are no models that have been widely prospectively validated to characterize masses benign or malignant in this population. And so that's the other study that I'm involved in, my Iota, so masses in young people. And this is another international prospective observational studies where we're looking at the longitudinal behavior of adnexal masses in girls and adolescents.
Now you're experienced in doing research because it sounds quite easy in the way that it's an interesting topic, so you go for it. But I think you learned now that there's some pitfalls, that there's some challenges. So what do we start with? So I think it's a protocol.
Yeah, exactly. So you need a good protocol. I think if you're a kind of a junior member of staff looking to move into research, I think the most important thing is your supervisor and the group that you're working with. A project can sound amazing on paper, but unless you have the people around you to make it happen, it just will not be a high quality piece of work. So for junior colleagues, I would say find a supervisor who you get on with, who's engaged with you, make sure that the project is the right fit for you, and make sure it's in a place that works for your life. So working in London is great for my life. Coming to Leuven, that's opened a whole new world for me and opportunities for me.
Yeah, so that's what I experienced with the Iota group. It's really like being with friends. It's really enjoyable to work together. If you have to do it yourself, it's impossible first, but it's also not enjoyable. So speaking about work-life balance, this work is really life. Yeah. So you need a good protocol. You need statistics from the start.
Yes.
That's very important.
So and you need somebody who knows what statistics really are, because I think as medics, certainly we do a few lectures on statistics at medical school, but you really need a statistician.
It's theory, but in practice it's different.
It's very different.
And sometimes there are hidden pitfalls that you should not forget about. And it's good to have the statistician on board, because otherwise they will tell you you've done everything wrong. So the data are not really reliable. They're biased in many ways. So it's good to think and to brainstorm and take a long time before you get a final protocol. But
exactly, it needs to go through rigorous peer review really before you put it out there.
Yes, and then you have to go to ethics.
Oh yes, that's the next step. So you get all of your documentation done, and then there's all sorts of things with the documentation that you didn't realise you had to do. All the legal sides of things. So you suddenly become an expert in contracts and GDPR,
insurance.
Exactly, CE marking, whether it's a commercial project.
European Medical Device Regulation. It's a lot of interesting additional challenges.
So these are all the things that you just don't really think about when you're working clinically, and suddenly you have to deal with lawyers, you have to deal with the sort of healthcare service provision side of things, contracts, but it is really rewarding. And then you go to your research ethics committee and then you get asked about what you're doing and why you're doing it and whether it's okay for the patients.
Mm-hmm. And then you need an electronic patient record form or a study form.
Exactly, and that's where your computer scientist really comes in to help you. So we're very lucky. We have somebody within the Iota group. Shout out to Willem.
Willem, who is clinical data miner. So it's an easy way to collect data in a GDPR-proof way.
Exactly.
And pseudonymized. So when we collect the data, we don't know the name or any details of the patient, but of course it's you can always retrieve it locally.
Yeah.
And then again, the statisticians.
Yeah.
And then we analyze the data together, we discuss it, And then we start writing the paper.
Yeah, and I think one of the real skills that I've had to learn over the last couple of years of moving into this level of academia is, what is the story I'm trying to tell with my paper? I feel like when I was more junior, I just got the results and kind of wrote them up. But really, there has to be a message behind what you're publishing and why it's important.
True, but it all starts from a protocol, because your whole statistical analysis plan should be in the protocol already.
Exactly.
So you should think, what questions do I want to answer? And if you don't do this at the start, your study will not answer the right questions.
No, exactly. It's like building a house. You have to have the right foundations.
Yes. Okay. Nina, I thank you very much. I wish you the best of luck with your further research. And I thank you for listening to this podcast. And I invite you to come and listen to the next Iota Plus podcast. Thank you.
Thank you.